dean, and we have a team who are doing excellent work. Our chairman is Dr. Murlidhar Pai, and this program has become very, very successful, and we are really enjoying that in the different slots like CPAP, skill transfer, the KCOG National, KCOG International, and we thought that you are one among all of us that who have developed an excellent skill in the ultrasonography in various like fetal medicine, ultrasonography in others. I have heard you many times in many other subjects, but somebody told me that madam is very good in gynec ultrasonography. So I personally requested you to talk on gynec ultrasound because which is a very, very necessity for all our young gynecologists. Today, we cannot say that I have done a complete examination of gynec patient unless I do a gynec sonography, because sonography has become the eye of the gynecologist. I think everyone must get equipped with this knowledge. Everyone must do this gynec sonography after the clinical examination. Gone those days when we were obstetricians and gynecologists for 30, 40 years in the medical college. There was no ultrasound at all. Whatever we used to do a PV examination, we used to diagnose, go ahead with surgery. Many times we used to be wrong. Now today sonography has come in a so big way, particularly vaginal sonography, and Dr. Mala Sibal is going to highlight on this subject. And it is necessary that our younger generation should know you, madam, that how great you are in the field. I request our secretary, Dr. Vidya Bhatt, to introduce you, madam.
Thank you so much, sir. It's my great pleasure to introduce Dr. Mala Sibal, who's now almost, we are interacting so much that she's become a dear friend of mine. And same as Dr. Hiremat said, I've been waiting, Dr. Mala, to invite you to KCOG for almost 1 year. It's like from the start to get the dates, for a movie, how they wait. We have been waiting for you. And it's a great pleasure and honor to have you today for this skill transfer. And it's always nice to have the skill transfer in different aspects of gynae, that is ultrasound, endoscopy, and we did even on radiology. But today it is so nice that you're with us. You'll be telling us so many tips and tricks on transvaginal ultrasound. You talking about you is a joy because of your achievements. You have got more fame nationally and internationally also. And you've been author of the book on ultrasound and gynecology. And your course on gynec, you're the course director of Gynec Academy of Ultrasound, that is learning portal for basic and advanced training in gynecology. And that ISUOG International Faculty for Ultrasound Training, and your IOTA program, that is International Ovarian Tumor Analysis, has been a grand success, and you have done so many IOTA programs. I think BSOG also you have done, and even in Dubai I hear about your courses, so it is very, very popular. Published multiple articles in journals, you have a lot of publications, and delivered over more than 350 lectures in different countries, and a best outgoing medical graduate. So your academical foundation is very strong. So over to you, Dr. Mala, for your lecture on ultrasound.
Before Mala starts, I request our president from London to address the gathering. Kasturi.
Okay.
Yes. Thank you, sir. Good afternoon from London. Namaste to one and all. I bring greetings from our KCOG family. First of all, I immensely thank our whole KCOG KCOG team, headed by none other than our chief patron, Dr. M.G. Hiremat sir, and Dean, Dr. Hema Devakar, Chairman, Dr. Murlidhar Pai, and Vice Chairman, Dr. Sajjan, and Secretary General of KCOG, Dr. Vidya, for taking up these KCOG KCOG programs in a big way. They are real academic extravaganza, which whole of the state, not only the state, many other than state, many people look forward to join this KCOG KCOG program. And I immensely thank our very dynamic, very active Secretary, Dr. Bharti Rajshekhar, Treasurer, Dr. Durga Das, President-elect, Dr. Vidya Thobi, and our patron, Dr. Nagaraj Sir, and whole EC team of KCOG for taking up all the activities in a big way. And I immensely thank MJ Ramat Sir, our patron, for pitching in such an excellent speaker, Dr. Mala Sibal, for the talk on this KCOG KCOG skill transfer. Whom we could have had none other than Dr. Mala Sibal to transfer the skills in gynec ultrasound. She has done such a tremendous work in gynec ultrasound. She has so many academic programs. She has written books, so many publications. So she's a pioneer, not just to the state, national, and international level. So we are really very lucky to have a person who's who of gynec ultrasound, Dr. Mala Sibal, on this platform today to address our whole KCOG team, whole KCOG family of our state. I'm sure many delegates have joined, and all of them are looking for an excellent extravaganza from you, pearls of wisdom from you. So I'll not take much time. I'll not come in the way. People are waiting to listen to you. And thank you, Dr. Mala, for accepting the invitation from KCOG KCOG and gracing this occasion. Immensely thank you for taking up time from your real busy schedule to address all of us. And I once again thank our whole KCOG KCOG team and KCOG family, EC family, for taking up all the programs in a big way. And thank you all the delegates who have joined for this program, who are waiting to listen to the academic extravaganza. Thank you one and all.
Thank you,
good
Dr.
afternoon.
Dr. Kasturi Janimat, for those excellent words. And now over to Dr. Mala Sibal.
To start with, thank you very, very much for those really kind words. I don't know if I'm worthy of them, but I'm very obliged, and thank you very much. And I don't think I'm as busy as you think I am, but anyway, thank you very much. I know, taking time off on Thursday evening on a weekday is not that simple, and so I'm going to go straight into the topic. Before I start, I'd like to thank the organizers, in particular, Dr. Hiremat and Dr. Vidya Bhatt, for this invitation. I've been asked to speak on tips and tricks in gynecological ultrasound, and honestly, I think you can go on for 3 to 4 hours. And I really don't know, at what level we all may be, the participants may be. So it's a mixed bag. Some things may be very simple. Some things may be, more things that you may not have heard of, but I'm going to do my best. And I also thank the participants immensely for having joined in. Before we actually get into this, I wanted to highlight the fact that the status of gynae ultrasound, unfortunately, has not kept pace with advancing technology. In fetal medicine, we've made a lot of advancement. Any error in fetal medicine draws a lot of attention, but in gynec pathology, if you miss a malignancy, it seems like it's no big deal, which is really sad. We must move on with advancing technology. There's a lot of information now available to tell us that, that a particular, that a lot of literature available that we can read and study, and also fantastic ultrasound machines. And so now we must move on from ultrasound used as a screening modality. So initially when we did ultrasound, it was just to see, oh, I'm seeing some large uterus or I'm not. And even today, unfortunately, we get reports that said bulky uterus. Bulky uterus has absolutely no value to me. It doesn't tell me whether this is adenomyosis, whether this is a post-abortal uterus, whether it is a fibroid, and so on. We need to move from screening to diagnosis. I need to know, is this a fibroid that I can do a myomectomy on? Is this adenomyosis? And so she needs some other type of management. So unless I have a diagnosis, I cannot give the patient appropriate treatment. And we must be, today with our equipment is so good that we should move on and provide so much information that absolutely appropriate and customized management is given to every patient. So if I have made a diagnosis of fibroid, I should be able to map the fibroid, tell them this is a submucous fibroid, therefore she's having this amount of dysmenorrhea. This is the best way to approach the fibroid, to map out the fibroid so that all of them can be removed in myomectomy and so on. Unfortunately, this doesn't happen in gynae ultrasound because a lot of people are not aware about to the about the extent of information that can be derived from an pelvic ultrasound examination. And secondly, if one is not doing ultrasound, there is no real demand from practitioner for quality reports. For example, if you miss a fetal anomaly, you can be sure that clinician is not going to send you a patient again. But if you miss a gynae ultrasound, it's like, if you miss a malignancy in gynae ultrasound, it's never treated like a big deal. I think it should be. It's only then that we are going to be forced to read, study, and improve our skills in gynae ultrasound. So to start off, one of the first things I want to highlight is a very important tip is that in every case, we must do a transabdominal scan followed by a transvaginal scan. We should do both because the two complement each other. There is certain information that a transabdominal scan will give me. There's something that a transvaginal scan will give me. And together, I will be able to give the best possible report. This is done in all cases unless it's an emergency and there is no time to fill the bladder for a trans. I think somebody is drawing some stuff on the screen. I don't know if we can stop that. Okay. Okay, so it's a little distracting, but it's okay. So it's very important, and we do only a transvaginal sometimes, like there's an emergency.
Somebody is drawing something on the screen. Okay, madam, please.
Yeah, and they're all, I think everybody should be muted and should not drop it. The thing is, I get distracted and then my flow of thought goes. That's my problem. I'm not capable of, not noticing it. So anyway, so we do both in every single patient. We do only a transvaginal scan, for example, in a patient with a ruptured ectopic. I'm not going to tell her, please fill your bladder, and then I'm going to do a transabdominal, then a transvaginal, because I know this is an emergency situation. Or sometimes the patient may just decline a transvaginal scan, or she may not be married, and obviously in such cases sexually not active, and in such cases we don't do a transvaginal scan and we restrict ourselves to a transabdominal scan. It is very important that the technique is standardized, fixed, and predetermined. Not today I'm focusing on the adnexa, tomorrow I realize there's a cervical malignancy. We have to look at all the structures in a fixed, predetermined manner. And we have the IETA, the IOTA, the MUSA, the IDEA consensus statements today that provide standardized, internationally accepted terms, definition, and measurements and ways of measuring for evaluation of the endometrium, adnexa, and myometrium, and these should ideally be adhered to. So let's start off with the first of these, and that is transabdominal imaging. And for transabdominal imaging, which many people don't do, I want you to know that the bladder need not be very full. Some people fill up the bladder so much that the pelvic structures go far away from the probe and you cannot see it properly. So if you have, for example, I'm doing this scan and my probe is directly above, I'm not able to see the entire uterus, the uterine fundus and the upper portion of structures above the uterus. I won't be able to see, I'm not able to see well. So what I need to do is move this probe down and angulate it towards the uterus. So you see, I'm going to place my probe down and angulate it towards the uterus, and then I'll be able to see well. So this is a short video clip to tell you how you can do a quick transabdominal scan. It doesn't have to be very long. It is very good for an overall survey of the pelvic anatomy. So here you see, I start off with the probe in front, and then I move my probe down, angulated, and you can see the entire uterus right up to the fundus beautifully. You go from one end to the other end, you see both ends of the uterus. Then you take a transverse section and you move up. And as you move up, you must see the entire endometrial line, whether you're doing a transabdominal or a transvaginal scan. One way of not missing a uterine anomaly is to see the endometrium go as a single unit right up to the fundus and disappear altogether. Then I know I have a normal endometrial cavity. Can you see that? Right over here, you can see the entire endometrium is a straight line. It is disappearing. It tells me there's no uterine anomaly. I always measure the uterus on a transabdominal scan because the uterus sort of gets flattened out. So it's very easy to measure the entire uterus body and cervix. And I evaluate the endometrium completely on a trans. I'm going to go back to that. Completely on a transvaginal scan. I look for any pathology. I do the Dopplers. I do everything on transabdominal scan because I never know whether I'll be able to see the endometrium well on a transvaginal scan. So I evaluate the endometrium completely. And then, of course, you have a good look of the adnexa and you see there's nothing in the adnexa. And I do a quick Here you can see, I know exactly now where the ovaries are. If there's any adnexal pathology, I'm able to place where this adnexal pathology is. And then in that area, I can study in great detail on a transvaginal scan. So why do we do a transabdominal scan? We do a transabdominal scan because what happens is with a full bladder, the bowels get pushed to the upper abdomen, and we know bowels have gas shadows, and therefore you don't see structures beyond bowel. So it pushes all the extra pelvic, non-pelvic structures like the bowel up there, and what is left behind is only the pelvic structures. And then you have a full bladder which acts as an amazing window through which you can see all the pelvic structures. So the beauty of transabdominal scan is you have a lovely panoramic view, and you can spot even the slightest abnormality because you have a good view of the entire pelvis, ironed out view of the entire pelvis, and you can spot any pathology. You can locate structures like the ovaries, and that area then can be studied in great detail with a transvaginal scan. Next thing is, we all know that large pelvic masses cannot stay in the true pelvis, and then these structures move out into the abdomen, and then they're too far away to be observed or to be evaluated carefully on a transvaginal scan because the structure is moved too far away from the vagina. Also, structures that are seen above the uterus, like a pedunculated subserous or a subserous fibroid above the uterus, you may not see it on transvaginal scan, and therefore such structures are better seen on transabdominal scan. In a dermoid, for example, here you see on a transvaginal scan, I'm not able to see the superior aspect of the dermoid. I'm just seeing the inferior aspect of a dermoid, whereas on a transabdominal scan, I'm able to see the entire dermoid. One of the reasons for this is on transabdominal scan, I have a greater range of approach to the mass. So if I have a mass, I can move on one side, I can go anterior to it, I can go on the right side. To some extent, I can push in and see both superiorly and inferiorly. It's only the posterior aspect that I cannot see at all, or I cannot approach the posterior aspect. Whereas in transvaginal scan, I just have one transvaginal probe which reaches the lower end of the mass. I cannot go to the left, I cannot go to the right. So the access, the range at which you can access, if there's some structure that is causing shadowing, I'm limited because I cannot move around on another side and look at that structure. So that is a big advantage of transabdominal scan. The endometrium of a mid-positioned uterus is better seen on transabdominal than on transvaginal scan, and we'll come to that in much more detail. Again, uterine anomalies are often better seen on transabdominal than on transvaginal scan, not only in a mid-positioned uterus. Mid-positioned uterus, of course, everything, the endometrium, the endomyometrial junction, the 3D, everything is very much better seen on transabdominal. But even if it's not a mid-positioned uterus, sometimes we see better on we see much better on a transabdominal scan, because on transvaginal scan, the cervix is in one plane, the uterine body is in another plane. And if you have two horns, the two horns and the two endometrial cavities may be in two different planes. So you have one endometrial cavity and horn, the other endometrial cavity, and then the cervix and the cervical canal in three different planes. On transvaginal scan, it's very, very difficult to get a single coronal rendered image. But with a full bladder, the uterus sort of gets flattened out, and it's much easier to get a single coronal image of the uterus. So here you see, I've done a transabdominal scan and a transvaginal. Both I can make a diagnosis of the uterine anomaly, but you can see, you know, just by eyeballing, subjectively, you can see that my transabdominal image is better than my best transvaginal image. Then if transabdominal scan is so good, why do we do a transvaginal scan? One, because it provides a close-up view of structures. Our probe is very, very close to the structure, and therefore we get beautiful resolution of these structures. Here you see, this is a scan where, of course, the bladder is a bit too filled, but you don't suspect any lesion because the ovaries sort of look normal. They're lying behind the uterus. But on a transvaginal scan, there were multiple small endometriotic cysts. So what happens is you can see these. Okay, sorry, I got distracted. So you can see this much better on a transvaginal scan. Again, because of proximity of the structure, there's very good texture determination and characterization of pathology. So if you're looking at an adnexal mass like you see over here, you can see over here that this, you can see a multilocular mass. You see some septae, but you can't see the features so well. Whereas on transvaginal scan, you can see these solid papillary projections in the septae. And when you zoom in, you can further see very well all these solid papillary projections arising from the septae, helping us in characterizing pathology. Again, if you want to differentiate between an adenomyoma and a fibroid, the visualization on transvaginal scan is much better. Doppler flows, again, are often much better assessed on transvaginal scan because the proximity of the structures. Most of the pelvic structures are very close to a probe transvaginal scan. So very often we are able to see Doppler better. But of course, if the mass is much higher up or the uterus is mid position, then a transabdominal scan may provide good information. Now, what is the best part about a transvaginal scan is the fact that you can, it's doing a transvaginal scan is like doing an internal physical examination because you can touch different structures during your transvaginal scan with the ability to simultaneously see those structures. So one is seeing the structures, one is touching the structures, but to be able to see and touch simultaneously is something which only a transvaginal scan provides. Even a CT and MRI cannot provide this facility. And this helps us with figuring out which is a structure which is tender. Are there adhesions between two structures? Are they sliding? Are they moving apart? And therefore, it's an interactive and dynamic examination that no other imaging modality provides. Now, when it comes to the endometrium, you see the endometrium is measured in a variety of ways, and measuring the endometrium is very important. So I've just highlighted this to say that the endometrium is measured wherever it appears thickest or maximum in the mid-sagittal plane. How do I know if you look at people, if you look at images that come to you, any plane is there. It may be a coronal plane, it could be any plane. We must get the mid-sagittal plane, and a mid-sagittal plane means the cervical canal should continue in a single in a single curve as the endometrial cavity, and the upper end of the endometrial cavity should be curved. Then I know I'm in the mid-sagittal plane, and in that mid-sagittal plane, you take a 2-layer thickness perpendicular to the endometrial midline, not a slant or an angle like this. You take it perpendicular to the endometrial midline. You exclude the hypoechoic inner myometrium or the junctional zone, and that is how you take the measurement and provide it in millimeters. Now, if there's intracavitary fluid, you can take only one wall and call it single layer thickness, or you can add the anterior and posterior and provide a 2-layer thickness. Endometrial pathology is best studied in the pre-ovulatory proliferative phase because a proliferative phase endometrium is a beautiful 3-line endometrium. Here you can see this is again a proliferative phase endometrium. You're seeing 3 lines, and any disruption by any pathology in this uniform 3-line pattern stands out beautifully, and you can easily pick up endometrial pathology. So the best time is the late proliferative phase between day 10 to day 12. Polyps, in fact, may be missed in secretory endometrium. Now, when it comes to a mid-position uterus, you cannot see the endometrium properly. You cannot evaluate. I'm seeing some cystic spaces, but I'm not able to evaluate this endometrium properly because the endometrium is lying parallel to my ultrasound beam. Remember, if you cannot see something well, report that you have not seen it well. So if you have a mid-position uterus, I think if everybody can turn off their videos, it won't distract me. Let me see. Yeah, sorry, I'm done. I'm able to remove the rest. So in a mid-position uterus, it becomes very difficult to study and measure the endometrium. If the endometrium is not visualized clearly or cannot be measured or anything, please report it as non-measurable or suboptimally assessed because your reports must have credibility. If I say the endometrium is normal and there is no pathology, it should be normal when they're doing a hysteroscopy. If I say there is an endometrial polyp, there should be an endometrial polyp. But if I see something like this, I don't know whether there is a pathology. I should be honest and say there's no, I don't know because I couldn't see very well. And that is very, very important because next time they know that when I see and when I say it is normal, they know that is the normal scan. When I say there's a problem, they know they can confidently take that patient up for hysteroscopy. And when I haven't seen, I'm being honest and they can use some other modality or their clinical acumen to try and figure out what the pathology is. Evaluating a mid-position uterus is very often a challenge, and what is very important to understand when we are doing pelvic ultrasound is on grayscale, any structure which is perpendicular to the ultrasound beam is well seen. and on Doppler, flows that are parallel to the ultrasound beam are well seen. So this would be an ideal situation. My probe is perpendicular to the endometrium, and if there is a vessel coming in parallel to my ultrasound beam, it is very well seen. So that is why I prefer to do a detailed evaluation on the endometrium or a trans-abdominal scan, because sometimes on transvaginal scan, we do not get the setting. So let's look at this case of a retroflexed uterus. Here you can see this is a mid-position uterus in contrast. Here the ultrasound beam is perpendicular, almost perpendicular to the endometrium, and therefore I can see the endometrium beautifully. Here the ultrasound beam is parallel to the endometrium, and therefore I cannot see the endometrium properly. Now over here, in such cases, one trick to do is to place your probe in the anterior fornix and push the uterus, push the cervix backwards to tilt the uterus forwards to try and get this endometrium more perpendicular to the ultrasound beam. But if that is not possible, you can place your probe in the posterior fornix. And again, you can push the cervix forwards to tilt the uterus backwards so that you get the endometrium a little bit more perpendicular to the ultrasound beam so you can see the endometrium properly. But this is very easily said than done. Very often it is not possible because there may be adhesions posteriorly because of endometriosis. There may be adhesions anteriorly because of a cesarean section scar. And so it's easy to say sometimes it is possible, but very often it is not possible. That is why I evaluate every case, the endometrium of every case on a trans-abdominal scan. Here you see this was a patient post-abortion. You can see over here that the endometrium is thick. There is a vessel which is a feeder vessel or some flow entering these retained tissue from the posterior wall at the fundus. And this endometrium is perpendicular to my ultrasound beam, and therefore I'm able to see it pretty well. Now, this is the same case on a transvaginal scan. I cannot even outline the endometrium because it's lying parallel to my ultrasound beam. And the vessel that I should have seen approaching this endometrium perpendicular, approaching this endometrium from the posterior wall at the fundus is perpendicular to my ultrasound beam, and therefore I'm not able to see it. So if I was to do only a transvaginal scan in this patient, I wouldn't be able to give the clinician any information, whereas with this, I was able to give information, and that is why it is important to study the endometrium in every patient on a trans-abdominal scan. Remember, on grayscale, structures that are perpendicular to the ultrasound beam are well seen, whereas on Doppler, flows that are parallel to the ultrasound beam are well seen. Another very important structure that has gained importance of late is the endomyometrial junction, and this is an area that we must all observe. We may have a patient who complains of infertility, she may complain of excessive bleeding, of dysmenorrhea, and it's very, very important in every single case. Put it in your checklist, the endomyometrial junction. So here you see the endometrium looks sort of okay. You can see a proliferative endometrium, but I want you to focus on the endomyometrial junction. Can you see how irregular this endomyometrial junction is? This is the junctional zone. You can see there are cystic areas, there are some hyperechoic lines over here, and all these are features of adenomyosis. So you see over here, there's a cystic space over here. There is an endometrial bud over there. I'm going to move forward. Can you see that's the cystic area? There are some hyperechoic foci over here. There are endometrial lines. The whole of the endomyometrial junction is disrupted. The zone looks extremely coarse. I'm going to stop over here. I want you to, see this. This is endometrial tissue growing into the myometrium. This is adenomyosis. So you can see the endometrial tissue actually going into the myometrium. And you also see hyperechoic foci. Now, I'm going off from this junctional zone into one very interesting feature that I've noticed. And that is whenever you have endometrial tissue that has gone into the wrong place, like in adenomyosis, like in deep infiltrating endometriosis of the rectum, deep infiltrating endometriosis of the vagina, scar endometriosis, anywhere where walls of an endometriotic cyst may show these hyperechoic foci. These are nothing but cholesterol crystals as a result of chronic repeated bleeding from the endometrial tissue. So this hyperechoic foci, whenever you see somewhere, think, especially not when it is on the surface of structures, when it's on the surface of an ovary, when it's on the outer surface, no, but when it's in the inner surface of a ground glass cyst, when it is in the myometrium, when it is in the any lesion in the abdomen suggestive of scar endometriosis, in deep infiltrating endometriotic lesions, you may not see them in all, but if you do see them, think in terms of endometriotic lesion or adenomyotic lesion. So this is something I wanted to show. These hyperechoic foci tell me the endometrium has visited the wrong place. So here it is in the myometrium. Then I want you to know that if I want a coronal view of the uterus, the best way to do is 3D and 3D with a coronal rendered image. So you take a 3D sweep and you render it in the coronal plane, and you can beautifully see the coronal section of the uterus, the endometrial cavity, beautiful triangle. You can see the outer serosal surface of the uterus, and you can see the endomyometrial junction beautifully. Now, this is a normal uterus, and here is a uterine anomaly. Remember, I get a lot of references saying, do a 3D. This patient has adenomyosis, has a polyp. They think 3D is an advanced version of a gynae ultrasound, and anything that you could not see on 2D, you will suddenly see on 3D. That isn't true. I want to remove this myth about 3D. 3D is very useful, but not everything is diagnosed. An error in diagnosis is not because 3D was not done. And a diagnosis suddenly doesn't become super terrific after a 3D. There are certain conditions where 3D is essential. For example, a uterine anomaly. I cannot classify a uterine anomaly unless I have a 3D. So I don't know whether it's partial septate, whether it's arcuate, whether it is complete septate. I will not know that without 3D. So 3D is essential in certain conditions like pelvic floor assessment, like uterine anomaly, to know the location of an IUCD, how it is placed in relation to the endometrial cavity. There it is essential. In some conditions, of course, it is useful, like in the case of a submucous fibroid. So here we have two fibroids. This fibroid is actually reaching close to the endometrium, but not distorting it. This one is actually flattening and distorting the endometrial cavity. So many of these submucosal fibroids, you get very good images when you do a 3D. That is where it is very useful. And in some conditions, it just helps me, it reassures me, or it is an additional modality to reconfirm what I saw. So here you see, remember that patient with the disrupted junctional zone. I know that this patient has adenomyosis, and I know that the endomyometrial junction is terribly disorganized and disrupted. And I reconfirm what I've seen on 3D. So here 3D helps me confirm or reiterates the fact that yes, this is adenomyosis, but I can make a good diagnosis even without it. Here it is useful because I may not know exactly the way it's distorting without a nice 3D image. You can actually walk through these volumes and see. And here, of course, it is essential. So remember, 3D is useful, and the utility varies with the pathology we are studying. Another very important thing to understand is, for a good 3D image, you need a good 3D image. So if I have a mid-position uterus, I've had patients who've been sent to me saying, referral slip saying 2D imaging was suboptimal, reported because of a mid-position uterus. Kindly do 3D for better evaluation. 3D is not going to give me a better image. I have to have a good 2D image. When I have a good 2D image, only then from that 2D image can I get a good 3D image. So that's something we all need to remember. Moving on to 3D, there are 3D workshops which go on for a whole day telling you how you can optimally visualize. But the commonest utility of 3D is to get a coronal rendered image of the uterus. And to get that coronal rendered image of the uterus, what is very, very important and what is very simple, if there's one thing I have to say, how do you get a good coronal image? Once you have taken, typically we take the sweep with a 2D image of the uterus in a sagittal section. So once I've got this image and I've taken a sweep, the machine will automatically give you 3 sections, A plane, B plane, and C plane. And the only trick is to get your green line, which is typically we curve it because the endometrium is most often curved. You should get this green line parallel to the endometrium in A plane and B plane. So no matter what you do, you get a nice parallel view, the green line cutting through and parallel to the endometrium in the A plane and B plane, and then you will get a beautiful 3D rendered image. So here is the IUCD lying beautifully well placed within the endometrial cavity. I don't have to worry about how this image is going to be turned out. All I need to know is the endometrium, the green line that I have on A plane and B plane is parallel and along the endometrium. Then coming to locating the ovaries, this is something everybody tells me I have a big problem. Very often I can't find the ovaries. How do we search the ovaries? First of all, do a transabdominal scan prior to a transvaginal scan. It will immediately tell you, oh, the left ovary is lying above, because left ovary is very often, just like the left kidney is placed higher up, the left ovary is very often placed above the uterus as compared to the right. I'm not saying always, but in a large percentage, when you can't find the left ovary, think of looking at the ovary above the uterine fundus. Sometimes even the right is above, but the left is very, very often above the uterine fundus, especially if you can't locate it, think it's probably over there. But for me, it's very easy because I do a transabdominal scan in every single image, so in every single patient, so I know where to search. Next, it's very, very easy to search these ovaries, most often in women of the reproductive age group, because they have a large number of follicles, and they're larger in size. So moment you angulate your probe to the right or the left, you can spot the ovaries. The other thing that you can do is to actually follow the utero-ovarian ligament. So you take a transverse section of the uterus. If you cannot find the ovaries, you take a transverse section of the uterus, go to the cornual end, one cornual end of the uterus, and then you angulate your probe towards the lateral pelvic wall, and you will see this dark utero-ovarian ligament. Just follow that ligament, and it will typically lead you to the right ovary. And same way, if you tilt, very often it will lead you onto the left ovary. But sometimes this is not good enough, because utero-ovarian ligament may not be well seen. And what I found useful is to actually trace the blood vessels that are there along the utero-ovarian ligament. So you have this anastomosis of the ovarian and the uterine arteries, and they will actually lead you onto the ovary. So here was a postmenopausal lady. You see, from the long section, I moved on to the transverse section of the uterus. Then I go to one cornual end of the uterus. I tilt my probe, and I use Doppler, and on Doppler, you can actually see that vessel leading on to the ovary. So you can see over here, it's actually taken me onto the right ovary over here. And what is interesting, it usually goes to the infero-lateral aspect. It doesn't reach the ovary medially. It typically goes infero-laterally, and here you see the atrophic right ovary. Now I've come back onto the transverse section of the uterus, and then I want to look at the left ovary. So I try and see, I don't see the utero-ovarian ligament, but I see a nice curved vessel over here. On Doppler, you can see this curved vessel, and this tells me that the left ovary is sitting above the uterine fundus. So it's actually flipped up. The vessels have gone up to supply this atrophic left ovary above. So sometimes if you cannot figure out with just 2D grayscale, you can use Doppler to locate the ovaries. Coming to fallopian tubes, remember, normal fallopian tubes are difficult to visualize unless there is some fluid. And here you can see the fimbrial end of the fallopian tube, lying close to the ovary after ovulation, ready to pick up the released ovum, I guess, in this patient. So this is how you can see the tubes beautifully, normal tubes in patients where there is fluid in the pelvis. Of course, deceased tubes are very easy to pick up. So if you have a large mass like this, you can see the ovary below over here. Most often in PID, the ovary and the tubes are together. The ovaries, because of fibrinous exudate, they form a teomass. And whenever you see incomplete septate, turbid fluid, thick walls, and high vascularity, you know that this is a pyosalpinx. So this was a PID. Coming to measuring any structure in gynecology, remember, to measure any structure, we must get the volume of a mass. And to get the volume, we must measure the mass in 3 dimensions. To get the mass in 3 dimensions, we must have an image of the mass in 2 planes perpendicular to each other. One should be a plane where the component appears the largest. So what I do is I go around. This is, for example, I'm giving you an example of an adnexal mass. It could be, it's the same logic for any structure. So I go around wherever I feel I'm getting the largest dimension of the mass. I take that image and I rotate my probe a little so that the longest dimension lies almost horizontal on the screen, that is perpendicular to my ultrasound beam. Then I freeze the image and do a 90-degree rotation and get my second image. So now I have 2 images of the mass in 2 planes perpendicular to each other. I cut across maximum dimension in the first image. Perpendicular to that is my second measurement, and across the screen where it's maximum is my third measurement. And then most machines will automatically give you the volume. Otherwise, you can multiply these 3 dimensions by 0.5 to 3 to give the volume. But most machines may give the volume. Remember, it is only volume that will tell you whether a mass is regressing or it is growing. A few years back, I was traveling from Bangalore to Delhi, and there was a person sitting next to me, a lady, and she watched me work on my slide. She said, excuse me, do you do ultrasound? I said, yes. She said, I have a question. Can I ask you? I said, yes, you can. She said, I have a very interesting mass. So I said, yes. She said, the first time I went, the mass was 5 into 6 centimeters. I said, okay. She said, and when I went 6 months later, it became smaller. It was 5 into 5 centimeters. I said, okay. She said, but that was not all. The next time I went, it was 6 into 7 centimeters. So my mass is growing, becoming smaller and bigger. I don't know what type of a mass. Obviously, a persistent, long-standing mass like this is not a physiological mass that is regressing and growing. It is just that we are measuring each time she goes to a sonologist, the person or even the same person measures in any possible direction, any 2 measurements. Remember, it is impossible to know whether a mass is regressing or growing if you randomly give any 2 measurements, because masses are not round spheres, right? They are shaped like this. So I can give, hello? Okay, so I can give any odd measurement. That is not the right way of measuring. When we measure properly, whether I measure or you measure or anybody else measures, the measurement should be the same. Then coming to Dopplers, remember Dopplers, earlier we used to get these pulse wave tracings and we used to see the RI, low RI means malignancy, means infection, what is the peak systolic velocity. But most of the studies today have said there's so much of overlap between benign and malignant that they've done away with pulse wave velocities. I think somebody is not muted. Okay.
Please mute everybody around.
Okay.
Yes,
so
sir.
what IOTA has now done is they have come up with color score. Color score is a subjective, semi-quantitative way of evaluating flow within a mass. So I just look at a mass or a structure and I say, oh, do I feel there's no flow? Then I call it color score 1. If I see minimal flow, I call it color score 2. Like you can see in this mass, just little bit flow, you have to actually search for it. If I see moderate flow, I call it color score 3. And if I see abundant flow, like in this high-grade serous carcinoma, I call it color score 4. So all you need to do is to subjectively evaluate no flow, minimal flow, moderate flow, and abundant flow. But what is very, very important is Doppler setting. So if there's one thing that I'd want you to definitely remember from today's talk, is that Doppler setting is very, very important. Every mass that you see, every lesion that you see, please use Dopplers. And when you use Dopplers, do not use color Doppler. You must use power Doppler or HT flow in almost all conditions in gynecology, with a few exceptions like an AV malformation, etc. In all other cases, you must use power Doppler or HT flow because they can pick up low velocity flow and flow in tiny vessels which cannot be picked up with color Doppler. Secondly, bring down your PRF to 0.3 to 0.6 because if the PRF is high, again, you will miss flow which is in small vessels and low velocity flow. And the last is your Doppler gain should be maximum without artifact. So what you do is, instead of pressing on the color Doppler knob, you press the power Doppler or HT flow. Make sure your PRF is set to 0.3 to 0.6. And what I want you to know is try and keep the setting constant, because after some time you get a feel, you get used to your machine and your settings. And then moment you say, oh, this is lots of flow, this is less flow. So I, for example, most often keep it at 0.6. And if I don't see flow, I bring it down to 0.3. But others, for example, I know Dr. Sonal's baseline is usually 0.3. And once it is, so she is used to a certain, even I can keep it at 0.3. But try and keep it standard, and then you can move up and down depending on what you feel like doing. So set your PRF to 0.3 to 0.6. And then increase your Doppler gain till you begin to see artifacts. The moment you see artifacts, you stop and you turn down your Doppler gain till the artifacts just disappear. That is ideal Doppler setting, because only with that, after some time when I look at a mass, I say, oh, there's very minimal flow here. There's maximal flow. I cannot say that unless my Doppler settings are appropriate. And that is important because of subjective pattern recognition. Remember, you can have all sorts of logical ways of thinking, but pattern recognition is very, very important, particularly in adnexal masses. You look at a mass, you say, this looks like a dysgerminoma. That may be a granulosa cell tumor. So to be able to just, what is pattern recognition? If I see 10 dysgerminomas, When I see the 11th one, the memory in my brain tells me, oh, looks just like the others I had seen. I may not be able to describe in words, but the first few have left an impression in mind, just like we differentiate our friends. You have hundreds and thousands of people in the world, but your friend, the moment you see even a photograph, even nowadays, or this AI will immediately spot, okay, this is Mala, or this is so-and-so, and this is so-and-so, just by pattern recognition, right? That is pattern recognition. We must all try and get into pattern recognition. We must follow up our cases so that after a period of time, when we look at a mass, we say, oh, that looks like a granulosa. Better ask her to do a inhibin B level because this looks like this type of tumor. So very important for pattern recognition, Doppler settings should be appropriate because moment I see more flow, I'm thinking in terms of a malignancy or an infection. I'm going to highlight the Doppler settings. The biggest advantage of Doppler settings is this case that I'm going to highlight with the help of this example. This was a 34-year-old patient with an 8-centimeter endometrioma who was on treatment for infertility. She was operated with partial cystectomy with the idea to retain her fertility. And the histopathology report came as endometriotic cyst. I saw her 3 months post-operatively, and I was surprised. Not only did the cyst fill up, but there was this large, solid, irregular mass with central flow. You see here, I've used color Doppler because this is an old case of mine. At that time, I didn't know that power Doppler is much better. So here you see, moment I saw this, it looked like this could be malignant. I went back and looked at images that were available, and I realized this mass was there even earlier, and it had been evaluated with Doppler, and it had been reported as a clot within the cyst, a fresh bleed within an endometriotic cyst. But the problem, this is because the PRF was set too high at 1.3 with a lot of turbid fluid. The sound beams had hardly reached this area, and therefore they thought it is avascular clot and not solid tissue. And here you can see the PRF is 0.6. This patient did get operated, and it turned out to be an endometrioid carcinoma arising in a background of endometriosis. So in this patient, a malignancy was missed only because the Doppler settings were not appropriate. Remember, the biggest advantage of Doppler is to confirm that this is solid tissue, particularly in adnexal masses, and solid tissue increases the likelihood of malignancy significantly. So you must evaluate any hyperechoic area that you see within a cyst. You must check for flow to know whether it is a clot, it is some amorphous material of a mucinous cyst, or it is some, in dermoids, you may have hyperechoic fat and sebum inside. Please evaluate with Doppler. If it is solid tissue, you should see flow within it. But to check for flows, make sure your Doppler settings are appropriate. Now, in an endometrium, when you have a thick endometrium, Doppler gives you a very good idea. If I have a single prominent vessel or a pair of artery and vein entering this thickened endometrium, I'm thinking in terms of a polyp. If I have multiple vessels in a focal area, like this, you have multiple vessels in a focal area, then I'm thinking in terms of a focal endometrial carcinoma. If I have multiple linear vessels scattered all along the endomyometrial junction, and they're entering the endometrium like this, running an almost parallel course, and if it's very vascular, I'm thinking in terms of an endometrial hyperplasia. Even secretory endometrium may appear like this, but endometrial hyperplasia, the vascularity is slightly higher. And when you see vessels like this, just like a splash in the endometrium, there is no uniform pattern, no parallel flow, not all the vessels are crossing the endomyometrial junction. In this thickened endometrium, I'm thinking in terms of endometrial carcinoma. So if you have some amount of endometrial tissue, I'm not talking when you have cystic spaces, but if you have a good amount of endometrial tissue, your vascular pattern may help you make a diagnosis. Coming to mapping, how much time do I have? I don't know the time. Oh, I'm very, very late.
You have time.
Okay, tell me when I have to stop because I think I'm running a little late.
Okay.
Okay, so when we are doing fibroid mapping, remember, diagnosing fibroid is nothing great. Fibroid mapping is what is required in today's world to say that you are doing a justice to your patient. And for fibroid mapping, that mapping means locating the fibroid within the uterus. And for that, I must know the morphological center of the uterus, which is the endometrium. So the first thing when I do mapping is to trace the endometrium. When I know the endometrium is here, I know F1 and F2 are anterior wall fibroids and F3 is a posterior wall fibroid. And once I map, remember, ultrasound scan is a live, it's not like X-ray or MRI. So I must draw an image, because here you can see, I can see only 2 fibroids. This third fibroid was in a separate plane. So we always draw diagrams to send to our referring clinician, sometimes in one plane, sometimes in 2 planes, sometimes in a long section, transfer section, and coronal plane, so that the gynecologist or the referring clinician knows where all the fibroids are, whether they are symptomatic. If they're doing myomectomy, what should be the approach to the fibroids to make sure that they don't miss? You can remove these 2, but you may miss this fibroid, which may slowly go into the endometrial cavity, to ensure that the fibroids are tackled beautifully, particularly in women who want to conceive. It is very, very important that proper fibroid mapping is done. Now, this was for example, I'm just giving you one example. This was a patient where you could see the fibroid lying within the endometrial cavity, and the endometrium is around it as if it's holding on to this fibroid. But you can see a part of the fibroid was extending outside the endometrial cavity. Basically, this was a fibroid that was arising from, it looked like there was an extension of this intracavitary fibroid outside, but basically it was a left corneal fibroid that was protruding into the endometrial cavity. So I drew a sketch like this to show the clinician, and this is literally the sketch that I had drawn right after my scan. And she said, oh, that's very simple. All I need to do is make a nick over here in the anterior wall. I will dissect out the anterior wall, and on the left side, I will dissect out this fibroid, and this portion will simply come out very easily because it's just lying suspended within the endometrial cavity. And that's exactly what she did. She dissected this part, and you can see from the endometrial cavity, this part came out very easily, and this is the fibroid. Remember, this was possible, and the approach was very, very easy because she knew exactly where it is located. So if we want to give our patients the best possible management, we should be able to map fibroids very properly. Sometimes you're confused when you see a hypoechoic structure, whether it is solid or cystic. Remember, the best way to assess is to know Dopplers, but other things that can help is if you see acoustic enhancement, this is the mass, beyond it, it's much brighter. It is more likely to be cystic, not always, because this is solid, and even behind this, there is acoustic enhancement. So acoustic enhancement is not a strong feature to differentiate between cystic and solid, but cystic tends to have better acoustic enhancement as compared to solid most often. But what really helps is Doppler flow. When I see Doppler flow within any hypoechoic structure, I'm 100% sure this is solid tissue, because you can never have vessels running inside turbid fluid. So moment I see flow, and that's why I'm saying Doppler settings are very important, because they tell me this is solid and not thick turbid fluid. Other things that can help is the movement of a clot. Somebody is speaking again. The other things that can help is movement of a clot. So you apply pressure and you release, and you see this jelly-like movement. I know it's clot. And also you will never see flow inside a clot. You see flow in the walls of the cyst, but you will never ever see flow inside a clot because there are no vessels. And this tells me this is a hemorrhagic cyst. And very often these patients come to us from the gynec onco department saying that this is a complex cyst with solid area and septae, and all it is a physiological hemorrhagic corpus luteum. The other thing you can do when you have such thick turbid fluid is to apply pressure and release and look for fine particle movements. And when you see these movements, you know that this is thick turbid fluid and not solid tissue. Now coming to adjusting gain, sometimes you see that you increase the gain, it looks like it's got low level echoes. You decrease the gain, it looks anechoic, and you're wondering which of these is correct. The best way to do is to compare with the bladder. In a patient with a normal patient with no urinary pathology, the urine in the bladder should appear anechoic. If the urine in the bladder starts appearing bright, that means your gain is too high, and you should bring down the gain, because the urine in the bladder should always be black. Now you come to something called a hyperechoic line. I have found that during ultrasound, when two smooth surfaces are in opposition, you get a nice bright hyperechoic line, and that is seen, for example, when the smooth anterior and posterior wall of the endometrium are in opposition, you get the endometrial midline. Again, when you have a polyp and the endometrium, you again get this bright hyperechoic line, and this tells me this is a benign polyp, because when smooth surfaces are in opposition, then you get this bright line, and smooth surface means this polyp is very likely to be benign. Again, I have found that useful in picking up a vaginal septum. So here you see, I place my probe in one hemivagina. This is the bladder, And you can see just here between the bladder and this probe, can you see this bright line here? This bright line is the opposite hemivagina's lumen, the collapsed lumen on the opposite side. So this is one hemivagina where my probe is. This is the septum. This is the lumen of the opposite hemivagina, and this is the opposite vaginal wall on the other side. So this, I don't even need to put gel. I don't need to do anything. I know that there is a vaginal septum because of the presence of this bright line. And this was a case with a septate uterus and a septate vagina. Now, sliding sign means you apply pressure on one structure and the other structure slides. So I'm applying pressure on the uterus, and you can see over here the ovary is sliding. So I know this ovary is not adherent, it is mobile. In contrast, in this patient with endometriosis, I'm applying a lot of pressure. That's the right ovary, that's the left ovary. No matter how much pressure applied, there's no sliding. The patient will complain of a lot of pain. And these ovaries are densely adherent, not only to the uterus, but you can see even behind the uterus, they were adherent to each other. And these are the so-called kissing ovaries seen in endometriosis. So when you press on one structure, normally the other structure will slide. But if the two structures, just though there is no sliding movement, and very often the patient complains of pain, you know that these structures are adherent. Now, when we don't specify which structure, when I just say sliding sign present, which we do in every single report, it means I'm talking about sliding of the bowel behind the uterus. This is very, very important because every surgeon wants to know the bowels. If it's going to be a frozen pelvis, you see this bowel sliding beautifully behind the uterus. So I know this is high and low sliding sign is present. So the clinician is very happy that if I have to operate a patient like this, it's going to be easy. Here was a patient, her ovaries look normal, and I just couldn't get the sliding sign. So when I can't push, here you see I push the uterus with my probe, with my transvaginal probe, whereas here I couldn't, even after I applied pressure on the uterus with my transvaginal probe, I couldn't see sliding of bowel. So I use bimanual. You can see that's my hand. I'm trying to press the bowel with my hand and see if I can make it slide somewhere on the uterus, and I see it is just not sliding. In fact, there is compression. You see, there's only compression, but there's no sliding. Again here, only compression, no sliding. And here you can see the ovary was also adherent to the uterus. Nothing was sliding. Everything was, if I applied pressure, there was only compression. And this is because this patient was a patient of DIE. This is a rectal DIE lesion. You can see on long section, this is the rectal DIE lesion. Over here, you can see this. And I just want you to know that normally the anterior muscularis of the rectum has a thin white line separating the inner circular from the outer longitudinal fiber. And in one place, suddenly you see a thickening, diffuse thickening with the loss of this linear appearance over here. This bright line is lost in this. This is a DI lesion, which is typically most often adherent to the uterus. So this was a case of DI of the rectum, as a result of which, and here in this patient, therefore, we say sliding sign is present. In this patient, we say sliding sign is absent. Now, even if you don't find a DI lesion, a deep infiltrating lesion of the rectum, moment you have an absent sliding sign, it means that the bowels are adherent to the posterior vaginal fornix and uterus. And as an isolated marker, it has a very high LR or likelihood ratio of 23.6 for rectal DI. So even if I don't see rectal DI, there is a probability that there is some rectal DI which I'm not able to see because of bowel shadowing. Now, an advancement from sliding sign is the splitting sign. In splitting sign, the two structures not only slide, but they move away from each other, and that is a splitting sign. Here you see, I'm seeing three cysts over here. I want to know which of these is ovarian, which of these is not. So I apply pressure over here, and you see first, even before I apply pressure, I see a little notch over here. Moment I see a notch, I feel this and this are likely to be two different structures. In addition, I'm seeing antral follicles, which are typically seen along the margins of the periphery of an ovary. You may see them in the center, but typically the periphery also has antral follicles. So the fact that I'm seeing antral follicles here makes me feel that this is the ovary, and this is probably something which is not the ovary. And further, I apply pressure with my probe, and you can see the two structures move apart, telling me that this is parovarian and this is ovarian. So this is the splitting sign. In such patients, we say splitting sign is present. Now here, another thing that can sometimes help you is to see the Doppler flows to know the origin of a mass. So say I see a mass over here. This patient had 5 ultrasounds and an MRI before she came to me. The reports were endometriotic cyst, paraovarian cyst, degenerating fibroid. And the MRI said finally that this could either be a lesion from the ovary or a degenerating fibroid. And this is what this is a transvaginal scan. This is the mass, that is the uterus. And here you can see over here, that is the ovary. And here I could not see any attachment of pedicles, so I used Doppler. And while doing Doppler, I could see flow from the ovary onto this mass. So I knew that, can you see? This is the ovary, and you can see flow from ovary onto the mass. The pedicle is hardly seen, but you can see flow onto this mass. So I knew that this mass was arising from the ovary. It was an ovarian fibroma. And this is the still images over here. You can see flow, very, very narrow pedicle and an exophytic large ovarian fibroma. On surgery, they said an ovarian tumor was excised, which was arising from the right ovary with a thin stalk. And the histopathology was a right ovarian fibroma. So if you can't see a pedicle, so all these sliding signs, Doppler flows, you pick up little techniques to try and figure out where this mass is arising from. I think this is my last or second last slide. And remember, reproducibility is important. If I see a structure and I'm not confident what it is, I must look, even if I'm confident, I must try and see that structure in multiple planes and using multiple modalities. Only then will I be confident about my report. So here was a patient at the end of the pelvic scan. You can see the bladder is filling up. And this is the cervical canal. I was looking at the cervix most often at the end of my scan. And when I was looking at the cervix, I realized that there was this cervix, but there was this hyperechoic line over here. I don't know if you all can see that hyperechoic line. Moment there's a hyperechoic line here, I thought maybe this is a polyp that is lying within the cervix. I wasn't very sure. So what I did was I took one image in a long section and then I rotated my probe 90 degrees and I realized, yes, there is a structure that is lying here. So this structure was not something I was imagining. If it was an artifact or if it was something I was imagining, I wouldn't be able to see it again after 90 degrees rotation. Also, this is also very useful when you're seeing postmenopausal ovaries. Very often you think, oh, this is a postmenopausal ovary I'm seeing. You rotate your probe and you realize it's become a nice long bowel loop. So whenever you see a structure, rotate your probe and see if you can see that structure even after 90 degrees rotation. So here you see, I can see that polyp. And then I said, now how do I further confirm? So I applied pressure with the transvaginal probe. You know, it's an interactive examination. So I'm applying pressure and you can see that this polyp is moving independently within the cervical canal. That further confirmed. And then I said, okay, let me use Doppler to see where this polyp is arising from. And you can see it was arising from the posterior wall of the cervix, mid-cervix. So here you see there is a less chance of error if the structure, the pathology you're thinking of is seen in multiple planes. Here I did 90-degree rotation and using different modalities. Here we use grayscale first when I raise a suspicion. Then somebody is talking and then we touched this polyp and we could see it move. And then we use Doppler to confirm. Similarly, that's exactly what I said about 3D. So 3D, remember, if you use only 3D for making a diagnosis, I do a lot of ultrasound, gynae ultrasound training. A lot of people share their cases and, they make a diagnosis of Asherman's on 3D. You must make a diagnosis of the structure first on 2D and then confirm on 3D. So that's a great add-on modality in most cases. There are only few conditions where 3D, like I said, is very, very important for making a diagnosis like the type of the uterine anomaly. But in most structures, it's a great way to reconfirm what you've seen. So remember, reproducing what you think is a pathology, using multiple planes, using multiple modalities will increase the accuracy of your diagnosis. Now, this was a patient who was diagnosed with a cervical, I think I have to move this, yeah. She was told that she had a cervical ectopic pregnancy. She was given injection methotrexate, and after the injection, she had heavy bleeding, and she was brought to us for a rescan and for appropriate management. So this is what I saw. You can see the ballooned out cervix over here. That was the trophoblastic tissue on transvaginal scan lying within this cervix. You can see that significant thick trophoblastic tissue and the collapsed, the irregular gestational sac. and the uterine arteries were seen above this whole pregnancy and trophoblastic tissue, and there was flow seen in this trophoblastic tissue. So I told the patient, the patient was there, and I was looking at the thing, and it so happened that the patient's attender was with me, and actually the husband was with me, and he said, you know, it's really funny. He was very tense because she was bleeding so much. And he said, you know, it's very strange. You know, you keep saying this is cervical ectopic. Somebody gave me methotrexate. First person told me, no, this is an intrauterine sac. I mean, I don't know what's happening, and I'm very, very concerned about my wife. So I said, do you have all your reports? Because she had come in from the emergency with massive bleeding. And I didn't have time to go into details, but I still told him, do you have the reports, because of what he said? And he said, yes. And I forget the reports. I just saw this one image, and I was surprised. The sac was actually in the lower uterine cavity, and you could see very clearly that the cervical canal was absolutely normal. So moment I saw this, I knew this is not a cervical ectopic. I looked, and you know, I was still doing my scan, and you can see beautifully here that this pedicule for this entire pregnancy is coming from the posterior wall of the uterus. The whole flow to this pregnancy is from the posterior wall of the uterus. So this was basically a pregnancy that was in the process of abortion. It was just lying within the cervical canal. It still retained its blood flow from the uterus, from the uterine cavity, from the uterus above. And then finally, I drew this scan. So, I drew the scan later to explain to the husband what happened, because he was so distressed. But the patient had, I told them that it is just a pregnancy that was arising, a little low-placed maybe pregnancy from the mid-corpus, which had prolapsed into the cervical canal on its way out. And she had an absolutely uneventful, simple ultrasound-guided evacuation. We just went in, did a suction, and it was done. If it was really a cervical ectopic, it would have been a real challenge. We don't know whether we had to do some, uterine artery, whether we had to put a balloon in, what we would have done, whether another methotrexate, because she's already given methotrexate. It would have been extremely stressful. But the moment I saw this previous report, I was 100% sure, further reconfirmed with what I saw over here. I was so sure that this is not a cervical ectopic, it's just on its way out. And therefore, the importance of getting your previous reports. Remember, I have multiple cases where people, even the person before me, had called it a cervical ectopic, based on which an injection methotrexate was given. If they could have easily asked, have you had any previous reports, and looked at that previous report and scan image. There are so many patients whose previous reports are completely missed, and a wrong diagnosis is made. Most of these sonologists have no time. They're like 20, 30, 40 scans a day. You're not even reading the beta HCG. I had a patient who had a beta HCG of more than 1,000, who was sent for a rescan to me because the previous sonologist had said that it was a multilocular solid mass. So they thought it's a corpus luteum with clot around it. They hadn't used Doppler. It was stage 4 serous carcinoma, and it was reported as a hemorrhagic corpus luteum. And they had not even read that the beta HCG was 1,000. Now that is really, and the same, within 2 hours, she came back to me because the clinician said, there's something wrong, Mala, with 1,000 CA125. No, I said beta HCG, I think by mistake. A CA125 of more than 1,000. This cannot be a hemorrhagic corpus luteum with clot. So I looked there, and it was a stage 4 serous carcinoma of the ovary. So it's very, very important to read your history and the previous investigations of the patient and the reports that the patient has come with. History and clinical. So to conclude, history and clinical findings should be noted before we begin to scan. Because say a patient comes with saying she has post-menstrual spotting, and you say, I found a subserous fibroid, great, you must report a subserous fibroid. But have you solved, or have you looked into the issue? There may be a cervical cesarean scar defect there, and that cesarean scar defect may be the cause for a post-menstrual spotting. You just tell her, oh, that's because of the scar, and she's relieved. But otherwise, she'll go from one scan to another scan. They'll say, oh, maybe there is a polyp. Why is she bleeding? The patient must have an answer to her problem. So we must see the history and clinical findings before we scan. We must specify if she's complaining of pain, dysmenorrhea, if she's complaining of painful coitus, if she's complaining of bladder symptoms, look for bladder DI, look for rectal DI. So the way and the detail with which, and the areas which you'll focus on will obviously depend upon the clinical features of the patient. Remember, TS and TVS complement each other. There is no shortcut to this. If quality of reports have to be good, both have to be done. The approach should be systematic. Not that I find an adnexal mass and I'm so lost in it that I miss an endometrial polyp. She has a surgery and they don't do a hysteroscopy because we forgot to look at the endometrium properly. So no matter what we see, we must see all other structures, the uterus, the endometrium, the myometrium, the endomyometrial junction, the cervix, the ovaries, the bladder, the POD, beyond it, adnexa, TS, TVS, everything should be done. Carefully observe 2D, it gets clearer as one continues to observe. So if we are doing really quick scans, the amount of time we are using our head to process what we are seeing is less. Every screen that I shot, every screen image that I see, my brain is working and working. When I change my probe, rotate, my brain is working again. So you must go on looking at 2D for some time, if particularly in challenging cases, and slowly you start, it will be like a web gets cleared and you say, this is what it is. That's why it's looking like this. So the more you see, the better you understand what you're seeing. Timing of ultrasound, remember, if very often people with infertility send their patients on day 2 scan. Day 2 scan is good for an antral follicle count before you begin. But day 2 scan doesn't help me with endometrial polyps. Day 2 scan doesn't help me with Asherman syndrome. So if you're sending a patient for infertility scan, please send in late proliferative phase, day 10 to day 12, because that's the best time to have an overall view of the entire endometrium, know whether she's ovulating, to see whether the endometrium has Ashermans, whether there are polyps, etc. Specifically for endometrial polyps, day 10 to 12 is great. When you want a nice 3D coronal rendered image of the uterus, like when you want fibroid mapping, you want to know how much it is indenting the endometrium. You want to know the type of the endometrial anomaly, the uterine anomaly. When you want nice 3D rendered images for any pathology evaluation, you must call the patient in secretory phase when the endometrium is thick, echogenic, and stands out beautifully in contrast to the myometrium. When you're looking at ovarian cysts, you don't know, there was a cyst, don't know if it's disappeared, call her in the post-menstrual phase, because if you call her premenstrually, again, a hemorrhagic corpus luteum may cause confusion. When in doubt, seek help from books, internet, seniors, and it's absolutely okay to delay reporting until then. There are many times when I see a case and I'm really stumped with what it is, and I tell the patient that I have not seen something like this. I would like to read up, or I would like to, ask a colleague of mine, and I will come back to you tomorrow. So they are most happy. Nobody gets upset if you tell them I'd like to further investigate or further read up and find out what this possibly is. Thank you very much for a patient hearing.
Thank you, madam. Vidya, can you take up the chat questions? Dr. Vidya.
Yep, I think Dr. Vidya,
Any questions are there in the chat box, Vidya?
No, sir, I don't see any questions, but of course there are very many appreciative comments for Dr. Mala. I would also like to compliment her for the excellent tips she has given. And the last note that you said, always delay the report when you're in doubt. Don't be in a hurry. I think this is what all of us should be ready to pick up a phone and call our colleagues, share the images, and get the opinion if we are in doubt. And the second thing is to corroborate the clinical history, the clinical findings, and the history is of utmost importance before we give the impression by the sonologist, because it does make a difference in many cases, just like what she said, that corpus luteum cyst was reported when it was actually carcinoma of the ovary. I think these are things that small tips, very important tips, which we should take it. And the other one, which was always do a transabdominal scan before you do the transvaginal scan. It is like mapping the abdomen and the pelvis, and then getting into the pelvis and clinching the diagnosis. Excellent talk, Dr. Mala. We appreciate your talk, and we will keep the session open if anybody has any comments.
Can you take up the chat? Any questions are there in chat box? Vidya?
No, sir.
Vidya is not there.
No, sir. She's not there, and there are no questions, sir.
No questions at all.
All no, sir. Only compliments.
Appreciations.
Yes, sir. Plenty of appreciation.
Kasturi, you would like to say anything?
Actually, very excellent talk and very informative. And the tips and tricks, like especially the tracing the ovary tube and Actually, as Dr. Mala said, whenever we have doubt, we need to communicate and to the radiologist or the gynecologist whom we are sending the clinical findings. So we may come to the conclusion better, because even if they know our clinical findings and history better, they can really focus on that when they're seeing, especially in complicated cases. As you told, even as hemorrhagic cyst, corpus luteum cyst was reported, and later it turned out to be choriocarcinoma. Even I had a case where it was similar. They are reported at this thing. Then when we went sent for a expert opinion, it turned out to be malignancy. So it can happen. So thank you so much, Dr. Mala, for those excellent tips.
Yeah, just to conclude, Dr. Mala madam, it was worth waiting for 1 year. I felt it is worth waiting for
No,
1 year.
You're making.
I know that you are doing
sound like
so
I'm
many
not awake.
gynec.
I'm usually very easily
Yeah,
available, but
I know that you are doing so many gynec training programs. I
Yes.
think you can take this KCOG platform also to train our youngsters, madam. And to conclude, you have covered basics also so well in the advanced talk. You have given so many bits, tips also, that how basically one should look into the sonography in all angles, in all plane. I think you have highlighted about transabdominal scan so well. Today's newer generation, immediately they put the vaginal scan and they go for a diagnosis and open the abdomen. They find that it is a distended bladder. I think that transabdominal is a must before doing any vaginal scan. Madam, you have coined one nice word, seeing and touching. I think vaginal scan is really seeing and touching. I think this everybody should know, that it is vaginal scan which gives you both. See, today ultrasound has become like for a cardiologist. He uses the stethoscope. He also uses his sonography, and that gives him a better idea. I think now every diagnosis we must complement with both transabdominal and transvaginal. Then only we can come to a conclusion. Madam, you being a gynecologist also and sonologist, you give so many things which are right from clinical examination to diagnosis and to management, and all in one screen, which was just wonderful. And you were all the images were so beautiful and so self-explaining. There was no need to explain again. And you have given so many different sections perfectly, and projected comparative images in a single screen. That was wonderful, that you gave in a single screen, which the textbook doesn't give. You have given all the images and self-drawn. That was very wonderful. All the images you have self-drawn, like our old teachers who were using board and chalk piece. I think that is the best way to teach a student rather than using all this higher technology. And you have given us a tip when to go for 3D. Definitely, you have said that 3D is all that not needed. You can diagnose many of them on the 2D only. And regarding Doppler, you have given all the information what it can add up to that. Definitely in differentiating between benign and malignant, identifying the origin of the disease, because always in anatomy you have learned, you go along the vessels, they will tell you the anatomy of the organ. I think you have beautifully explained that. Mapping of fibroid, you have wonderfully said that we must map on sonography and then we should do. So, madam, your talk was a dedicated sonography report. It is not just one report of a sonologist which has got some images and which has got some words. But your report was both a clinical and sonographical and management wise also. And these slides which our surgeons used to tell when we were undergraduates, sliding sign, splitting sign, moving sign, these I never heard in the sonography. You so beautifully demonstrated all these signs, made it very, very clear, madam. I think your talk was so excellent. We are very much delighted. We had a very good audience, nearing to 100. I think good number of people have come today and they have made aware. And I think you have made us aware about the sonography, so many new things. I think on behalf of KCOG family, I thank you very much for the wonderful talk. Please come again and again to this KCOG forum. It is your platform where you can be the best of the teachers, because you are a gynecologist, you are a sonography, you are a surgeon. So 3 in 1, yours is 3 in 1. And that is wonderful, the projection. Madam, once again, I thank on behalf of our president, whole team of KCOG, and all the today's participants. Quite a good number of participants are here. Once again, thank you. Whenever you are free, you tell. I know that you had some health problem of your parents. I could not get you, and then we had some other problem.
That was the
Anyway,
real reason,
it
sir,
was
not
a
because I
wonderful.
was busy. It was
And
my
you can use our KCOG platform to widen your the educational programs. I know that you are doing so many educational programs that you can use the KCOG also once in a while, once in 3 months or once anytime you are free. You can anytime you come on to the KCOG platform and use it and make this KCOG program a very, very interactive and a very, very informative also. Thank you once again on behalf of all of us, madam.
Thank you. Somebody wants to know about the training program. So,
Yeah,
so I
please,
will,
you can little highlight on the training program.
yeah, I will send that. I also want to say there is an IOTA course that I think Gulbarga will be organizing, the Gulbarga Society of OBGY, but I don't know the dates yet. It will be in August where you get a certificate from IOTA Europe. And for the rest of the training programs, I'll just write down, this is the website. I don't know. They can go to the website if they want.
Madam, you
and,
can just, we will share
yeah,
it.
and
You
I
can just
also tell
send
you
it.
that there's a number of a person, of that support person. If I can get her number, I will send that because somebody wanted to know. Yeah, her number is, her name is Pallavi. If somebody wants, they can contact her. Pallavi. And her number is 9325
Madam,
9325
little louder, madam.
Can you
Number?
repeat, madam? Louder.
9325 890 and 820.
Pallavi.
Pallavi, yeah. I put it in the chat box also. And the
Yes.
website
Thank
is
you, madam.
www.gynac.org, and Pallavi is the person who is the contact person.
Yes, madam.
So in case, and the IOTA program also, Pallavi will tell you once it will be fixed in a few days because I'm in talks with the Gulbarga OBG Society. So if it will be an on-site program because IOTA is keen that we do on-site and not online now that COVID is gone. So it might be an on-site program. Okay, sir. Thank you so much. First of all, to everybody who
Thank you very
joined in.
much. Even at the end
Thank
of the
you.
day, there are more than 50 people still
Thank you.
waiting for your last few words.
Remember me. I'm
Thank you, Dr. Mala.
Yeah.
It was excellent
Mala,
talk.
hope you remember me. You're junior to you in JNMC.